Tuberculosis is now almost exclusively, not entirely, but almost exclusively a disease of migrants in the UK. That wasn't always that way. This is the very helpful HPA TB report in 2009. And if you look at this graph, way back in 2000, in these bar chart bars for blue are the number of cases for UK-born TB, and the grey bars are the numbers of cases in non-UK-born TB. So right back in 2000, there were just under 2,000 UK-born cases and just over 3,000 non-UK-born cases. But as we go through the decade, you'll see that the number of non-UK-born cases has crept up and up and up. If we look at the current 2012 report, been just under 9,000 cases of TB, 74%, so 3 out of 4 cases of TB in the UK are from people born outside the UK. Just under 2/3 are of South Asian origin, just under 1/4 are of African origin. So this chart breaks it down in a little bit more detail. On the left here we've got numbers of cases and rates in UK born, and on the right here we've got numbers of cases and rates in non-UK born broken down by different ethnic groups. And just as before, there's just under 2,000 cases in white UK born, but the rate is very, very low in white UK born folk. In contrast, non-UK born TB, many cases in black African, Indian, Pakistani and mixed other groups. And if you look by contrast, those ethnic groups who are UK born, there are relatively few cases and rates are very much lower. If we look at the age range where TB, active TB is happening, this is youngsters, young adults, through to the elderly, the number of cases plotted against the left, and this is non-UK born cases. You can see that the majority of TB is happening in young adults, and there's a preponderance in males over females. When does the TB happen? It doesn't happen at the time of crossing the border into the UK. This is a graph here which shows years since entry to the UK. And you can see that in the first 10 years, cases of TB are arising with reasonable frequency. So even 5 years after arrival to the UK, there are over 300 cases of TB that have occurred at that stage. What the mechanism is up for debate. Is it vitamin D deficiency? It's all very exciting, but we won't go into it now. A really important feature of TB in the UK now is that it's largely occurring through reactivation of latent TB infection. The World Health Organization reckons that 1/3 of the world is infected with TB, which is latent TB, not active TB, waiting to reactivate. You've got about a 10% chance of reactivating that latent TB to active disease during lifetime. So this is work by Helen Maguire in London, and they looked at, if you like, the fingerprint of the TB cases that were happening. Were they one person transmitting to the next, or were they arising de novo from latent infection? And their conclusion was that it was arising from latent infection. The estimation now is about 80% of London's TB arises from latent disease. What about social factors in tuberculosis? This is from the 2012 HPA report. Well, 2.5% of cases had a history of problem drug use, 3.5% alcohol dependence, 2.5% homelessness, and 2.6% imprisonment. So 8.6% had at least one factor? Well, the corollary of that is that over 90% didn't have one of these social risk factors. So although TB is often reasonably portrayed as a disease of poverty and deprivation, the emphasis I'm trying to put here is that it's about migration and particularly reactivation of latent disease. Where's the burden of TB? It's happening in metropolitan areas. I've managed to switch that off, I think. My little light's gone. Let's go back. Oh, yeah, it's happening again. There we go. So this is London broken down here, but metropolitan areas, Glasgow, the North Midlands, Birmingham. This is where it's happening in London. You probably know all this, particularly Newham, West London, Brent and Hounslow have the highest rates. This is a chart that shows over the years how the rate has crept up overall in the UK, but particularly in London, rates of TB have risen. This is to show that it's not evenly distributed, it's not consistent over time. This is 2005 running through to 2010 in 3 East London boroughs. So Newham, the rates are rising. In Tower Hamlets, the rates are steady, and in Hackney, the rates have fallen, and we'll come back to that slightly later. So how do we compare with other cities in the EU? Strikingly, Birmingham has the highest rate of TB, 51 per 100,000. London, overall rate of 44 per 100,000. And you can see that we're much higher than these other EU cities, Berlin, Stockholm, Milan, etc., etc. The blue charts give the rates for the country, the red bars give the rates for the city. Even more strikingly, if we look at number of cases in EU big cities, the burden in London is astronomical compared with these other cities, even Birmingham. So London really has a huge burden of active TB. And this is just to mention drug resistance, that over the years, multi-drug resistant TB is creeping up slowly, and isoniazid TB, resistant TB, is also creeping up slowly. So just to summarise where we've got to, TB predominantly affects migrants, 3 and 4 cases occurring in non-UK born folk. Rates are low in UK born ethnic minorities. Rates are highest in cities. The largest burden is in London. Reactivation of latent TB is very important, and new cases are arising at least up to 10 years after arrival in the UK. So I think the essence of my talk is that there really is a key role for primary care in addressing tuberculosis, and this is a nice guidance now. And our role primarily, I believe, is to diagnose active TB early, to reduce diagnostic delay, and to identify people who've got latent TB infection so that they can be offered antibiotic treatment to prevent reactivation. So here's a good old Lower Clapton Health Centre in Hackney. How many cases would your average practice expect to see? Well, in North East and North West London, with rates of 70 per 100,000, this should actually say Birmingham, 50 per 100,000. You might see in a practice of about 10,000, you might see around 7 cases per year, and in Birmingham, the practice of 10,000 might be seeing 5 cases of tuberculosis a year. So TB is common, particularly in practices where there's a high turnover of patients. So what do practices, are practices aware of the amount of tuberculosis that might be occurring in their practice? Well, the Department of Health funded TB Alert to do a survey of awareness and to try to raise awareness of tuberculosis in primary care. And so these are the results of the survey. We included GPs, practice nurses, nurse practitioners, and we largely targeted the areas where TB was common. And here are some of the results. We asked practice nurses and GPs to estimate how many cases they would expect in their surgery. Well, it's a little bit difficult to interpret this data, but what's clear is there's a whole bunch of people who think there are going to be no cases of tuberculosis in their practice, even in these areas where tuberculosis is happening. Similarly, quite a lot of people reckon there's only going to be 1 or 2 cases of tuberculosis in their practice. So I think there's reasonable evidence there that we're underestimating the incidence of tuberculosis in our practices. So are we any good at diagnosing tuberculosis? Well, actually, it's quite difficult, and actually we're not very good. This is an interesting study which was done in Cardiff, unwrapping the diagnosis of TB in primary care, a qualitative study, and these people interviewed people, GPs and people who presented with tuberculosis in primary care. So there were a bunch of common symptoms that we all know are related to tuberculosis: cough, fever, sweats, weight loss, fatigue, and so on. But also a bunch of uncommon symptoms that wouldn't necessarily make you think about tuberculosis: headaches, thirst, back pain, and so on. There were typical presentations, not in ethnic minority groups. This is a 60-year-old male who's white, alcoholic, smoker, self-neglect, weight loss, chronic cough, pneumonia. Perhaps that might make you think of tuberculosis. But also atypical cases, a 50-year-old white male with shoulder pain, steroid injections for shoulder arthritis, who eventually was found to have TB on aspirate. So it's quite difficult sometimes to pick up tuberculosis. GPs were often reluctant to investigate to the patient. Why did you go to A&E rather than back to your GP? Well, because I wasn't having much done. He said it was flu. And I said to him, I think I've got TB. And he goes, that's not true. And I said, I think it's going to be true. And he goes, well, we're going to take you to X-ray. Atypical presentations: recurrent sore throat, hoarse voice, refer ENT. So that's how it was picked up. Another case, he could have just had very bad depression. He stopped eating and took to his bed. So there's a whole bunch of barriers to diagnosis, primarily a kind of reluctance to investigate, a low index of suspicion, as well as these other factors. Poor continuity of care, I think, is important these days. High workload, brief consultations at the coalface, and poor communication within practices. So is there any way of improving the way that practices, or the ability of practices to pick up TB? This is a study that we published about 6 or 7 years ago, where we trained practices in Hackney to screen for TB. And so all the practices, as warts and all in Hackney, not just the enthusiastic practices, took part in this study, and half of them were trained to screen for TB. And this was largely something that was carried out by the practice nurses, who knew patients, were asked if they had symptoms of TB, or they were contacts of TB, or they were migrants from a high prevalence area. And if so, they were either investigated for symptoms or they were screened with a HEAF test, tuberculin skin test, if they were under the age of 35. And I won't go into great detail about it. But practices seem to carry out these health checks, but they also indulged in opportunistic case finding. And the result was that there was an increase in the proportion of cases identified in primary care of active tuberculosis. So that was success. There was a slight reduction in diagnostic delay that wasn't significant, but importantly, looking back at the data, there was really no effect on the pickup of latent TB. These are just the time from first GP consultation to referral as query TB. In the usual care practices, it was about 60 days. In the screening practices, it was reduced, but not significantly. In another piece of work, we showed that screening was perfectly acceptable to migrants, very happy to be asked whether they would like a test for TB. Since the screening programme in Hackney's been in operation, there has been a reduction in the number of cases of TB in London. Is that an effect of the programme, or is it gentrification? I'm not absolutely sure. So where are we? Summary 2. An average practice in London might see 5 cases a year. We tend to underestimate the number of expected cases. Screening and case finding in general practice is modestly effective, and it's probably cost effective. But there's a big problem that it's not effective at picking up latent TB. And as I'll come on to in a minute, there's very little interest amongst commissioners across London in helping practices to start TB screening. So where next for TB screening in primary care? Well, you can see that London has a big problem with tuberculosis. So there's a group set up to address this problem. They came up with an ambitious target to reduce the number of TB cases in London by half over the next 10 years. And identifying active and latent infections is a key part of the goal that emanated from that group. The key issues, again, identifying latent TB. So let's just review what the NICE guidelines say about screening new entrants for tuberculosis. Under 5 years, MAN2 refer if positive, 5 to 15. MAN2 if positive, do an interferon gamma test. 16 to 35, interferon gamma test alone, or dual strategy with MAN2. Over 35, consider the risks and benefits of screening. One of the questions that was raised was what are these interferon gamma release assays? So I'll try and explain that briefly. There are two particular important things to point out. The first is that if I've been exposed to tuberculosis, my T cells will reduce interferon gamma, which is a cytokine which is typical of the response to tuberculosis. The second important thing to remember is that there are a bunch of proteins that exist on the tuberculosis bug which don't exist on the BCG bug. These proteins are called ESAT6 and CFP10. So T cells that are exposed to these proteins will release interferon gamma, and they'll release interferon gamma and demonstrate that that particular person has been exposed to TB, whether or not they've been exposed to BCG immunisation. So potentially this is a really important test. There are two types of interferon gamma release assays. One called quantiferon that measures the amount of interferon gamma that's produced, and the other a T-spot test that measures the numbers of T cells releasing interferon gamma. So here's a schematic diagram of how this works. In this top plate here, there's a bunch of monoclonal antibodies, and these are monoclonal antibodies that are raised against interferon gamma. So they're stuck on the bottom of the plate and their arms are sticking up, and they're waiting to catch hold of any interferon gamma that comes their way. In the second picture here, my blood, let's say, has been drawn from my arm. It's been mixed with these proteins, ESAT6 and CFP10, and it's spread into the dish. And because the T cells, let's say for example, my T cells have been exposed to TB bug, my T cells start releasing interferon gamma, and these antibodies that are stuck up with their arms in the air catch hold of that interferon gamma wherever there's a T cell that is releasing interferon gamma. You wash all the cells away, and then you layer on another antibody with a dye on the top. So wherever there has been a white blood cell, a T cell that's been exposed to tuberculosis and is capable of producing interferon gamma, it shows up as a spot of dye. So this is a potentially very important test. So I'd like to compare MAN2 testing versus interferon gamma testing. MAN2 testing is cheap, it's safe, but it does show cross-reactivity with BCG and environmental mycobacteria, particularly people from Africa. It's got to be done by a health professional, can't be done by a healthcare assistant. Sometimes technically difficult, it's got to have a second test for people to come back Good sensitivity for picking up exposure to TB, but can have poor specificity. That means that you can get false positives. An interferon gamma test is more expensive, appears to be safe. As I said, no cross-reactivity with BCG or non-tuberculous mycobacteria. Anyone can do a blood test if they're trained. It's technically easy, no second test, no second visit to read the test, and good sensitivity and better specificity. I think the important thing to point out is in our trial of TB screening, we were using a HEAF test, a tuberculin skin test. It just didn't work. We didn't pick up latent TB. We carried out 2,000 HEAF tests, but there were only 11 cases of latent TB. And this is a paper published recently by Manish Parikh. This has really changed my thinking about screening for latent TB and how we might do it in general practice. They screened 1,222 migrants using an interferon gamma release assay. Now, 20% of those were positive, showing that they had latent TB infection, and the remaining 80% were negative. And they calculated that if we'd followed standard NICE policy, we would have missed almost 3/4 of those cases of latent TB infection. And they carried out some cost estimates to see how much it cost to avert each case of TB, and they calculated that it would be reasonable to screen people who were from countries with a TB incidence of greater than 150 per 100,000. So that's basically Africa and South Asia. So current problems with TB screening in primary care. The MAN2 test doesn't seem to work very well. There's no system of quality control. There's a poor pickup of latent TB in practice, TB infection. Many practices don't do new patient health checks. If you have a program of training practice nurses to do tuberculin skin tests, there's a problem because there's often a high turnover, and so there's a continual demand to train new nurses that are being employed. Nowadays, health checks are often done by healthcare assistants who are unable to do MAN2 skin tests. And furthermore, as new evidence arises on other screening tests for other infectious diseases, we have to work out how to incorporate screening for TB with screening for other infections like hepatitis and HIV. So I'm thinking of a new model for TB screening in primary care, and that we should continue our active case finding with a low index of suspicion for tuberculosis. We should very much now focus on migrants because that's where the disease is. I'm thinking that we should try and switch away from the MAN2 skin test as a screening test, and we should start doing one-step interferon gamma blood tests in migrants under the age of 35. There's less training needed. There's no quality control because it's simply a serology blood test. And more importantly, it's extendable to lower incidence areas. I'm sure there are people from practices here who have relatively little tuberculosis, may see relatively few migrants, but they still need to screen those people according to NICE guidance when they arrive in your practice. So this is a model that will work if we get funding to use IGRA tests. So a person registers in your practice, they're asked questions whether they've got TB symptoms. If yes, then you'd proceed to investigate them with chest x-ray, send off sputum, blood tests, and make a follow-up appointment. If they said no, this is people under 35, then they'd be offered an IGRA test rather than a MAN2 skin test. If it was positive, refer to TB team. If it's negative, reassure. And if there's no BCG scar, do a BCG. This is for people who are over 35. If they have TB symptoms, then you'd investigate them as before. If they didn't have TB symptoms, then you'd reassure and give them a leaflet about tuberculosis, so that they were more aware of tuberculosis, and if they developed any symptoms, they would be more likely to attend. So in summary, TB is a significant health problem in the UK. We in primary care have got the potential to make a major contribution identifying both active and latent TB. The Department of Health is raising awareness for primary care, and on the Royal College of GP training, general practitioners training, part of the website, there are 2 new modules for TB in primary care, which I'd urge you to have a look. If you're a practice nurse, then you can nick the login from any of the GPs in your practice and look yourself. I think that TB screening has stalled in primary care. There's little interest in commissioners. From commissioners at the moment, who are much more interested in other things in these, as the NHS changes. And the current testing programme, I think, is complex and quite labour intensive. And I think that we need a new TB screening programme that's simple, cost effective and usable in high and low incidence areas of the UK. And as new evidence comes online for effectiveness of screening for other infections in primary care, we need a more sophisticated system where we integrate TB screening with HIV screening, hepatitis, and any other infections that are relevant. Thank you.